You can place a line now, but placing one is the easy part. The harder and far more important skill is knowing when a line is the right call, where it's a bad idea to put it, and what to do the moment something goes wrong. Most of the disasters in Roman 4 therapy aren't dramatic failures of the stick itself. They are complications that a switched-on medic catches early and a distracted one misses. So this section is your safety brain. Why you're starting the line, the patients and sites where you should think twice, and the local and systemic problems that turn a routine line into an emergency. Start with why. At your level, there are really two reasons to put fluid or a catheter in a vein. The first is volume and perfusion. The patient is losing fluid or can't keep up, and you need to support the circulation while you move them. The second is access. The line is a route to deliver medication straight into the bloodstream, where it works fast. At the EMT Roman 4 level, that most often means a fluid bolus or 10% dextrose, D10, for a hypoglycemic patient. Every line you start should answer one question out loud. Am I here for fluid or for a route to give a drug? Now where not to stick. Some sites turn a helpful line into a harmful one. Don't cannulate distal to an injury or a fracture. Fluid pushed in below a wound can leak into damaged tissue and cause real harm. Avoid an extremity with a dialysis AV fistula. That access is the patient's lifeline and a stick can wreck it. Stay off skin that's burned, infected, edematous or paralyzed. It heals badly and hides the early signs of trouble. And avoid the affected arm after a mastectomy, where lymph drainage is already compromised. When the obvious arm is off limits, choose another limb, not a worse vein. Local complications stay around the Roman 4 site, and they are the ones you'll see most. Infiltration and its irritating cousin extravasation top the list, fluid escaping into the tissue around the vein. Phlebitis is inflammation of the vein itself, from an irritating solution, the catheter rubbing the lining or infection. A hematoma is blood pooling under the skin, usually from going through the back wall of the vein. Add local infection at the site, occlusion where the catheter blocks off, and nerve or tendon irritation if you're stuck too close to a joint. None of these is rare. All of them are catchable. Infiltration deserves its own slide, because it's common and easy to miss. The fluid that should be going into the vein instead leaks into the surrounding tissue, and the telltale triad is swelling, coolness, and pain around the site. You'll also notice the drip slowing or stopping, no blood flashback when you lower the bag, and the patient describing tightness or burning. Coolness is the giveaway. That's room temperature fluid sitting in tissue, not warm blood. The fix is the same every time, and it's simple. Stop the infusion and remove the catheter, then restart in a fresh site with new equipment. If a medication was in the bag, document it and tell the receiving facility. Run the bedside, check the way you'll do it in the truck. Look at the site for swelling that wasn't there before. Touch it, is the skin cool and tight compared with the other arm? Ask the patient about pain, tightness or burning. Watch the drip and lower the bag below the site. Real venous placement gives you a flashback of blood. Infiltrated tissue gives you nothing. Any one of these can be subtle. 2 or 3 together is your answer. And the response never changes. Stop the infusion, remove the catheter, choose a new site. You are not flushing it, not nudging it, not hoping it settles. Systemic complications leave the site and threaten the whole patient, and 3 of them are killers you must never cause. Air embolism, air pulled into the bloodstream that jams the right heart. Catheter shear, and the catheter embolus that follows when a fragment breaks off and travels. And circulatory overload, too much fluid, too fast, backing up into the lungs. This is the overhydration link from earlier, and the usual cause is forgetting to slow the drip after flushing the line. Add sepsis from a contaminated line, and allergic or pyrogenic reactions to the fluid or its additives. If the line is patent and the patient is crashing, leave it in, you may need it. Here's where this gets personal for your exam and your patients, because the NREMT draws a hard line. On the skill sheet, improper technique that could cause uncontrolled hemorrhage, a catheter shear, or an air embolism is an automatic fail. Not points off, a fail. So is failing to dispose of your sharps immediately. The single rule that prevents catheter shear is the one to tattoo on your brain. Once the catheter is advanced over the needle, never rethread the stylet. A pinched catheter sliced by that needle becomes a free-floating fragment heading for the lungs. Place the line, drop the sharp in the container right then, and keep reassessing the site all the way to the hospital. So, know your why before you stick. Respect the sites you should leave alone and treat every line as something to watch, not something to set and forget. Catch infiltration early, never rethread that needle, and ditch the sharp the instant it's out. Next section, we put the whole skill together start to finish. Everything you'd read more on for this section is on screen.